Good evening, everyone.
Can you see my slides?
Everyone. I warmly welcome you all to another lecture from another lecture of the PeMSAA lecture series. So today's topic is going to be ophthalmological emergencies, which will be conducted by Dr.Saman Senanayake, a senior consultant ophthalmologist at National Hospital Kandy. He was graduated from Faculty of Medicine, Peradeniya in 1979, and he has been working as a consultant ophthalmologist for 20 years. He's a examiner in both undergraduate and postgraduate examinations. So without taking much time, I'll hand over to Sir to conduct today's lecture.
Okay, can you hear me, Kaushika?
Yes, I can hear you, sir.
Yeah, okay. Thank you so much, Kaushika, for taking a lot of trouble to organize this event. I think my audience is basically medical students, final years and fourth years.
Yes, sir.
And adding on to the introduction, I actually belong to 1979 batch. We had only 90 students in our batch. I'm sure that time in 1979, many years ago, I'm sure most of your parents are of my age. So it is quite interesting, but basically the structure has not changed much, but then activities have changed a lot, and I think we are doing much better than those days. So coming on to the topic, I think I have been given only 1 hour. So Kaushika, when Kaushika spoke to me, I told him that I have to break lecture into 2.
Yes.
Can you hear me?
Yes, I can hear you.
Yeah. Because, ophthalmic emergencies is a big topic. And it is important. It's an important topic also, both in your practice point of view as well as your exam point of view. Because most of the time we set questions on ophthalmic emergencies. And as you know, in any field of medicine, it's very, very important for us to know 2 areas basically. I may call this significant areas in whatever the field. One area is that we need to know about common problems, especially now say in my field it's going to be common ophthalmic problems. The second thing is to learn to manage ophthalmic emergencies. And in between, there's a very a large gray zone where you may be able to take some time to think about, and especially in your practice. So you need to know about ophthalmic emergencies as well as common problems. Now, coming on to ophthalmic emergencies, as I told you, it's a very, very important topic in your day-to-day practice. Wherever you work, you may be working as a medical officer in a peripheral hospital, or you may be working in a non-ophthalmic unit in surgical casualties, medical casualties, etc., etc. So I try my best to give some kind of light on ophthalmic emergencies. Now, for descriptive purposes, I try and divide into 2 areas: traumatic ophthalmic emergencies and medical ophthalmic emergencies. One thing is that we don't have time because I have been allocated only 1 hour. So perhaps we can do medical ophthalmic emergencies in some other session. So I will try my best to confine myself to traumatic ophthalmic emergencies today in this session. Now, as you know, history is very important for us to know. Going back to the history of ocular trauma or traumatic eye problems. During the period of 1908 and 1913, just before the First World War, which actually happened in 1913 to 1918. And this is actually the period where you call post-industrial revolution period, where people started using machinery, and all kinds of new machines have been invented, and then they use all kinds of machines. Before that, people were dependent on agriculture and basically on handicrafts, like handmade things. I think that the world would have been much safer than this era when you think about the pre-industrial revolution era. Now, during that period, since people started using all kinds of machinery, there have been a lot of work-related injuries. And 30% of intraocular foreign bodies, especially associated with metal chips, from the things like occupations like grinding, have been very, very common during that period. And then came the time period in between World War I and World War II. That is, World War I actually happened during the period of 1930 to 1918, if I remember right. And World War II was during the period of 1939 to 1945. And then, as you know, there have been so many deaths in both wars. And then the casualties have been much, much more severe during the First World War, nearing to 10 million civilian as well as casualties of people who fought the war, the soldiers. During the World War II, it was a little less, but then there have been about 20 million deaths of soldiers, and then about 3 times than that of civilian deaths. As you know, what happened, the disasters that happened during the period of Adolf Hitler in Germany, which get a real black mark in the history of the world. And during that time, they used a lot of explosives, shrapnels, etc. They experimented all kinds of weaponry, and then resulted in all kinds of eye injuries related to explosives and shrapnels. And then during the period of 1950 to 1976, many motor vehicles came into roads, all kinds of new brands and new inventions. And then there have been a lot of injuries with windscreen, and then only they introduced the seat belt law, actually, which has made a big impact in reducing the number of injuries. And then coming on to 1987 to date, there have been a lot of injuries related to war, sport, recreation, especially things like cricket, ice hockey, boxing, and then games like Scotch created a lot of injuries. And we'll just look at the impact of ocular trauma. Now, if you look at the nature of the injuries, and then the blunt injuries amounting to 80% of the traumatic ophthalmic injuries, and perforating about 13%, and intraocular foreign bodies about 1%. Unfortunately, we do not have figures in our country, like figures for representing whole country. There have been some studies done in several localities, but I don't have really the numbers at the moment to tell you. And in the UK, this amounts to about 4,500 admissions annually, and 236 led to complete loss of sight. And 50% of these injuries are actually home accidents. In Sri Lanka, if you look at, I think, number of admissions, I'm sure we are not second to UK. We see many of the injuries, ocular injuries, getting admitted to the eye departments. And just like in the UK, most of our injuries are, again, maybe about 50% are home-related, home accidents. And looking at the kind of trauma that you can see in the eye, if I am best to list out, starting with lid avulsion, Peri-Orbital Hematoma, blowout fractures, hyphema, sphincter rupture of the iris, hydrodialysis, renal detachment, corneal rupture, and then more severe injuries like ruptured globe, intraocular foreign bodies, chemical burns, and entity called non-accidental injury. We'll discuss all these things as we go on. Now, what happens in blunt injuries? What happens is the mechanical waves are transmitted through the globe, and then practically damage can occur to all intraocular structures, starting from the lid up to the optic nerve. So this is what happened when there's a trauma to the globe. The pressure wave is transmitted from the anterior aspect up to the optic nerve. So any of these, the ocular structures, including the conjunctiva, cornea, the lens, iris, the vitreous, retina, and optic nerve, all these structures can get severely damaged depending on the force of the trauma. Now, first thing that somebody might get with traumatic eye injury is a lid laceration. And it is so important that you need to check whether the rest of the globe or rest of the eye is okay. Because you may only see the superficial injury. As I told you earlier, injuries can occur in almost all the tissues. So please remember that there can be serious eye injury underlying to the lid laceration. Your management would be in situations where lacerations cross the lid margin, and if the medial canthus, lacrimal apparatus, levator complex, or those associated with low perforations should be referred to the eye department, because these areas are very, very sensitive areas, and if you do a wrong suturing or wrong alignment, may result in loss of function and severe disfiguration of the eye. As you know, eye is a very, very sensitive structure, and it's something very, very noticeable for anybody. So you don't have to unnecessarily mess around with your ocular tissues. Having said that, all the other lacerations in the brow, and then around the eye may be repaired with 6 nodes nylon or monofilament nylon. And do not forget your tetanus toxoid. Now this patient has a lid laceration involving the medial canthus. If you carefully see, here actually the punctum is right there. So this is called a caruncular avulsion, and you need to repair the punctum also. Otherwise, there will be a lot of functional problems like tearing, watering of the eye afterwards. So you need to refer this kind of patient to the ophthalmic department. And we have special techniques to do this kind of repair. I don't have time actually to describe the way we repair these things, but this is what you see after repairing. Peri-Orbital hematomas. I'm sure you have seen many of these hematomas in your surgical casualty. Usually, this results from a direct blow to the orbital margin. Remember again to check the ocular damage. Especially, this kind of trauma can cause orbital flow fracture and even low perforations, hyphema or blood in anterior chamber. And it's very, very important that you do the examination of the fundus to examine the retina for any injuries. If bone injury is suspected, you may have to do X-ray or a CT scan. And you can do your home remedies like cold compresses and some analgesics would do if there are no other injuries. You can always manage this kind of patient, but make sure that you are not dealing with internal ocular injuries. So please do examination to exclude any other associated injury. Now this is a peri-orbital hematoma. This patient has peri-orbital hematoma. Now you must try to open the lid and see whether there are any associated internal injuries. If you have any doubt, please do refer them to the eye department. Blowout fractures. Another common traumatic ophthalmic emergency that we see in ophthalmic units usually results from direct blow to the orbital margin. And symptoms would be pain around the eye and pain in eye movements, double vision, and paresthesia over the maxilla. Now, this is because of the damage to the infraorbital nerve which traverses on the floor of the orbit, so that this nerve can simply be damaged in a blowout fracture, so that this patient can have paresthesia over the maxilla. And signs you need to look for: enophthalmos, restricted eye movements, bony tenderness, surgical emphysema, and sensation. Check for sensation over the maxillary distribution of the maxillary division of the trigeminal nerve. Now management would be, ideally CT scan nowadays, you can get much more details of where exactly the fracture is. And if we are to decide on a surgical interference, you need to have a CT scan. And then if you have any doubt, please do refer this patient to ophthalmic unit or maxillofacial department. Now, if you carefully see this patient, in the middle picture, middle photograph shows straight eyes. When the patient on your left-hand side picture shows there's a defective up gaze. This patient is trying to look up on the right-hand side right eye. It's not moving up. And again, it's not moving down also if you look at the picture on the right-hand side. So this is very, very likely that this patient has blowout fracture and entrapment of inferior muscles, namely inferior oblique and inferior rectus. So this kind of patient would have severe diplopia in straight gaze and down gaze, and need to correct this problem surgically. And again, this patient, this is after repair of the blowout fracture. Again, the right eye is affected. Still, the movements are not full if you look at the slide, the picture on your right-hand side. But still, the movements are reasonable movement is there. Usually, it takes 2 weeks to recover because there can be a lot of edema around the surgical site and in around the eye. So it takes about 2 weeks to get good results. And this case, you see an obvious enophthalmos of the right eye. And then see a CT scan here, which shows a large, this cross section shows a large defect at the floor of the orbit. And then protruding of the ocular contents and including the muscle into the maxillary sinus. Now, this kind of patient needs surgical repair. There are some definitive indications for interference, like significant enophthalmos, more than 3 to 4 millimeters, and a significant diplopia, especially in straight gaze and down gaze. High femur now. High femur is again another common problem that you see associated with traumatic eye injuries. Causes again would be direct blow to the eye, and they can have blurring of vision, watering of the eye, and photophobia. And signs, obviously, you may see blood in the anterior chamber. In most of the occasions, you can diagnose high femur simply with your torch, and you need not to use a slit lamp by microscope, so that you can always use your torch all the time when you work in non-ophthalmic area. You can diagnose these things very, very easily with your torch. Management of high femur. Again, as I mentioned, you need to look for any other injuries like glaucoma perforations. You need to refer them to the eye department because they need specialized management. Usually they are admitted and they are given bed rest. We usually prescribe with topical steroids to counteract inflammation, and then they can have high intraocular pressure because of the inflammation of the trabecular meshwork, where the outflow of the aqueous is blocked. Thereby, they can have raised intraocular pressure. And we need to keep them involved for a few days because they can have what you call secondary bleed, which may be much more serious than the primary bleed, which may need surgical evaluation. So if there's significant high femur, usually filling more than half of the anterior chamber, they need admission. So if you see them, please do refer them to the eye department. Then we can sort them out. And this is a case of high femur. In addition to that, you see the subconjunctival hemorrhage there, and you see the blood in the anterior chamber. It's about a quarter of the anterior chamber is filled with. On this area, you have clotted blood, right? And remember, now this patient can have a lot of other ocular injuries. So it's much more safer for you to refer this kind of patient to the eye department after checking the visual acuity and record all your findings. Now this patient has sphincter tears, the sphincter damage, and they can have dense subluxation and sometimes more severe injuries in the retina, like retinal tears, and they can have even damage to the optic nerve. So be careful. Now here, as I told you, there are sphincter tears. That's why the pupil is dilated. So once the sphincter pupil is damaged like this, pupil just dilates. It won't constrict to the light properly because sphincter pupillary muscle is damaged. Now here in this picture, shows iris root dialysis. Like I said, it gives rise to a D-shaped pupil. So when the iris root gives away, like here, there's a large defect there. Now this patient can easily have a serious, severe high femur with this kind of injury. This actually, the high femur has settled. Now you see the real picture happening in the anterior chamber. In addition to that, the eye pressure or intraocular pressure can be raised, and they can have many more internal injuries. Ruptured lobe usually results from high velocity injuries, blunt or sharp. Symptoms would be severe pain and loss of sight. Obviously, they will have loss of sight, profound loss of sight. And then look for injuries like signs like subconjunctival hemorrhage, full thickness renal and corneal lacerations, and prolapse of the intraocular contents. Management. Remember your tetanus prophylaxis. If you suspect any intraocular foreign body or intraocular, especially metallic foreign bodies, or any other intraocular trauma, please do CT scan or X-ray. Because if you miss an intraocular foreign body, we'll come to that later on, patient can have all kinds of problems. And then all you need to do is put a plastic shield on and urgently refer this patient to the eye department. Try not to put any antibiotic drops or try not to exert pressure on the eye, because if there's laceration and when you pressurize the eye, more and more ocular contents can protrude out and bulge out and cause more and more damage. So don't touch the eye if you're not sure what you're dealing with. Just put a plastic shield on and then send urgently to the eye department. And there we will first do the primary repair to restore the normal anatomy or the integrity of the globe. And then only once the normal anatomy is established, we think about restoring the function or try to restore the vision. That's a secondary function. Now here, I'm not sure whether it's very, very clear for you. Is a scleral laceration. There's a large laceration of the sclera, and this black thing is actually the choroid. And then even the retina is damaged and the vitreous is bulging out. So this is a massive injury, very, very serious injury. And you need to, this needs repair as early as we can. So please do refer this kind of patient to the eye department. Try not to just pressurize the eye, put anything in the eye, no antibiotics, and just put a plastic shield on and then send to the eye department. Here, as you can see, this, look at the pupil. If you just with your torch, you can diagnose this. Pupil is not updrawn pupil. It's not nice and round, like, right? Your pupil has to be nice and round, and see the iris prolapse there, right? Now this again, scleral laceration, sclerocorneal laceration, actually laceration is right at the limbus, and then iris prolapse. This kind of patient again needs very, very urgent repair. Earlier, the better. You know, if you do it very early, outcome is going to be much better than late repairs. So again, plastic shield, if you like, do tetanus prophylaxis, and then send this patient to the eye department as early as possible. Now, this picture shows another corneal perforation, and it's a perforating injury again. See, this cornea is perforated, and these white things actually damage lens, and then release of lens matter into the anterior chamber. Another serious injury. This again needs repair as early as possible. So once they reach the eye department, we do this kind of surgeries under general anesthetic because we don't want to have moving or just squeezing patient, squeezing the eye and all kinds of problems. So we need a very calm and quiet patient. So we do this kind of repair under general anesthetic. Now, intraocular foreign bodies. There's a large spectrum. On this side, you have inert foreign bodies, starting from gold, platinum, silver, glass, and sometimes stone and plastic can be inert. But remember, if this patient gives a history of Soil contamination, you have to be very, very careful because they have a high chance of getting endophthalmitis or severe ocular infection. And then lead, zinc, aluminium intermediate. Iron is relatively toxic. And then copper, thorn, twigs, wood, soil are very, very toxic. And especially copper is very toxic. It can destroy the whole eye within 24 hours. Other things like organic matters, the danger is that they can cause severe ocular infections. So whatever happens, please do refer them to the eye department. They need to be sorted out very, very fast. And they need, if there's evidence of intraocular foreign bodies, most of them need surgery and removal of foreign body. Now, usually, causes would be very high velocity objects. And nowadays, we see many cases of intraocular foreign bodies associated with grass cutters. I'm sure you have seen, and the university you must have seen these people cutting grass with machines. And sometimes these people do not wear goggles. That's very, very dangerous. These tiny pieces of iron sometimes, breaking off from the blade, and sometimes stone particles can fly as long as 40 feet. So you must not be very close to the person who is doing this job, and please be careful. Sometimes the person who watches what's happening during grass cutting gets the problem because the grass cutter usually wear goggles. So it's very, very important that we make sure that these people wear goggles. Actually, most of the intraocular foreign bodies which I have seen in so many years of practice happen because of carelessness. Especially, it's like nail and hammer injuries and the mechanic repairing the gearbox. And all these situations, you need to wear goggles. That is something our people tend to forget. So we need to educate them. And I think the law is there that they have to wear goggles when they do jobs like that. But unfortunately, they don't practice this. So they need to be supervised properly. And symptoms would be a mild to moderate pain. Vision may be sometimes unaffected. I'll come to that later on. And signs may be minimal sometimes. Enterocyte may not be even visible. Management, probably any intraocular penetrating trauma needs a CT scan nowadays to exclude possible intraocular foreign body, especially metallic intraocular foreign body. And then you need to refer them to ophthalmologists. And systemic antibiotics like ciprofloxacin need to be maybe useful. But then many of them, if there's evidence of intraocular foreign body, need vitreoretinal surgery. Now these surgeries are very, very complicated, takes a lot of time. So ideal thing is to prevent these injuries. But once it happens, we need to do surgery. And if you carefully see, this patient has white opacity here on the lens, if you carefully see, that is because of a cataract. And here you see a very, very tiny hole in the iris. You may not notice this. And here also you see a brownish hyperpigment patch. There is something like that there. So you may easily miss this. You may just think that, cataract is secondary to trauma or something. So if you don't take a good history, you may really, really miss this intraocular foreign body. Now, when you examine the retina, you see a large, fairly big iron metallic foreign body lodging on the retina. You need to remove this. This is again a patient who had an injury with a grass cutter. while he was cutting grass, right? And then this is the foreign body, you need to remove that. If you don't remove this kind of metallic foreign body, especially copper foreign body, of course, you need to do surgery as early as possible, perhaps within first few hours. Iron foreign body, again, as you know, copper can ionize to C3, right? And iron also, ferrous can be ionized to ferric, and which are not very, very toxic, which can destroy the whole retina within a very, very short time. So you have to be very, very careful in dealing with intraocular foreign bodies. This is another foreign body. I don't know how the foreign body has gone into the subconjunctival space. This is a silver kind of foreign body, and you can always leave this kind of alone. But removal of this kind of foreign body is not so difficult. You can straight away remove. This is just subconjunctival foreign body. You see, I don't know how this heart goes into going into the subconjunctival space. And then we'll discuss another important area of chemical burns. As you know, chemicals can be in two spectrums, like it can be alkali or acidic. Now, alkali injury is known to be much more severe or much more damaging to ocular tissues, because alkalis do penetrate very, very rapidly. Whereas acids are equally strong, equally toxic, equally damaging, but acids aggregate proteins so that it prevents deeper penetration. Both are equally toxic, but nobody can say that acid is better than alkali. But then in a way, if you compare both, damage due to acids would be less than alkali. And symptoms would be severe pain and redness, photophobia, and blurring of vision. And usually these chemical burns are associated with burns elsewhere as well. You must remember, they can have facial burns and then burns elsewhere in the body. So be careful, and you need to attend to them as well. And signs would be they can have epithelial loss, corneal epithelial loss, conjunctiva can be severely injected or circumcorneal injection or circumcorneal inflammation, and chemosis or the conjunctival edema, and then ischemia to the limbus, leading to corneal haziness or corneal clouding, and then uveitis or severe inflammation of the anterior chamber. Now, I just want to make a point about limbal ischemia. I think we will discuss that later on in the next slide. So, and the management would be irrigation, ideally with 0.9% sodium chloride, at least 30% after 30 minutes, or even water until neutralizes the pH. Ideal thing is just tap water or whatever the water available. That is the most important first aid that you can do anywhere where you work, even in the household. It is important that you irrigate with water. Idea is to dilute the chemical so that injury is going to be less. And then second thing is that you just wash off particles, whatever the remaining particles of, if there are like solid particles, like in case of calcium hydroxide injuries or lime injuries, which is known to be very common in our country. You can have these tiny white particles of lime or calcium hydroxide. You can wash them off. Thirdly, it is very important that you reduce the contact time. with very, very sensitive ocular tissues. So once you reassure the patient and do your first aid, please do refer them to the eye department as early as possible. So there we have to plan specialized management depending on the ocular damage. Damage has already been occurred, by the time you send this patient. So initial first aid measurement is very, very crucial in this situation. So please remember that. You can do a lot wherever you work, or you can advise on patient and educate them on chemical injuries. And then admission, whether we admit or not, depending on the extent of the burn. And then we treat them with topical steroids, topical antibiotics, oral vitamin C, and then agents like tetracycline known to have anticollagenous activities, which is going to be helpful in chemical burns. And then they are naturally in severe pain because of the contraction of the ciliary body because of the inflammation. So we just make the ciliary body relaxed or pupil dilated using cycloplegic agents, and then topical steroids to reduce inflammation, as I told you, and antibiotics to prevent any possible infection. Now, looking at the spectrum of the chemicals that you see in household, now these are most of the things are in our household, like common alkali, like oven cleaning fluid like sodium hydroxide, drain cleaning fluid sodium hydroxide. Again, pH is around 14, it's very, very strong. And then plaster is calcium hydroxide. I just want to tell you a word about plaster. Now, we've seen many children, even now, coming with calcium hydroxide injuries. Way back in 1990s, when I worked with my great teachers like Dr. Abesing and Dr. Seaman, and we saw many injuries when I was a registrar in the ophthalmic department in Kandy. And almost we saw 10-15 patients, maybe perhaps during a month, with calcium hydroxide injuries, popularly known as lime burns or Schnapp burns. As you know, our people are used to use Schnapp for beetle chewing. So we have this Schnapp wrapped, and kept somewhere in Ilattato, whatever, they use the plate that they use for beetle chewing. I'm sure you have seen this in your household. And when we were small, this lime was actually wrapped in a banana leaf. So it's quite safe. And then people use not a banana leaf, dried banana leaf to wrap lime. And later on, actually, when the polythene came to the market, this is during the time of, I think, early 1980s. People started using polythene to wrap, to packet lime. So that, they just packet it and seal it. Most of the children used to play at the household. And then they just, throw these things up and then just try to catch them. And what happens is these things fall down and then splashes on their eyes. So that was a common mechanism of the injury those days. And we saw many children actually. And actually I don't know whether you have seen those posters we have created those days in 1990s. Now the prevalence is not that. It's less, but then we see occasionally injuries with calcium hydroxide injuries, so plaster or Schnapp or lime. And fertilizer like ammonium hydroxide is quite, again, alkali, like 13. And common acids, battery acid, sulfuric acid, its pH is 1. And then levotrichina, again sulfuric acid. Bleach like sodium hypochlorite, concentrated sodium hypochlorite is again pH is 1. And then pore draining fluid solutions like sodium hypochlorite can be really strong. And then common acid that we use in our household is acetic acid. I'm sure you have heard about acetic acid. Especially this is very commonly used in areas like in Kerala and the Southern province and Kalutara area, where they have this rubber tapping industry, and they use the acid to make rubber sheets. So the common kind of the history that we saw those days, I don't know whether I haven't seen that many patients coming and getting treatment for acid injuries. Those days, young people, many young people, actually they drank acid. Sometimes they, then going into the ice while they're drinking acid. Unfortunately, this is sometimes, they had all kinds of problems like love affairs and all kinds of things. And then this is the kind of thing they commonly used. Unfortunately, I don't understand why they didn't have any better way of committing suicide. And nowadays, the common kind of mechanism is that somebody splashes or throws these acids to take revenge. Unfortunately, we see a number of cases like, one case at least a month, like in the ophthalmic department. And then this is, here you see a severe acid burn. I just wanted to, I just mentioned about the limbus. Now the limbus is this area, the margin in between the cornea and the conjunctiva. Now here is the place where you have stem cells, which helps in creating normal epithelium. Stem cells at the limbus. This limbus area is so important. So depending on the burns involved in the limbus, we have a grading system actually. This is actually grade 4 burns, so very severe burns. And there's no chance of surviving or getting this vision back in this patient. Because whole of the limbus is very ischemic, as evidenced by this white area. Whole this area is burned. So there's no chance of regaining vision in this patient. So it's very important that we educate these patients, preventing all these kind of injuries. This kind of eye can never be recovered. And then non-accidental injury. This is another area where you have to be really careful. Now this is also called child battery syndrome. I don't know whether you have seen this kind of injuries, traumatic injuries, especially in children. You need to be very careful in taking histories and inquiring about these things, because not just these injuries are not existing in this country. We are really not looking for them. And it's very significant to get the proper history of these injuries, because most of the culprits or affected people are the children, and of course caused by their parents. Looking at the problem, about 35% of the serious eye injuries occur in children less than 12 years. So what are children? And 4% of the children attending to eye casualty has some kind of history of abuse, usually by their parents or close relatives. So you need to be very careful in taking the history, because if you don't take a proper history, you'll be exposing this child to again to same kind of environment, and then child may come back with a more severe injury even elsewhere. Now, who is affected? Most children are under 3 years of age. And parents tend to be very young, sometimes single parents from poor social circumstances with a history of being abused. So this is very, very important. But please do not think that just because we do not have this single parent business in this country, these things are existing. What happens is that, when there are problems in their families, all kinds of problems, ultimately their anger goes on the poor child. And in the West is quite common, especially so-called single parents or single mothers and single fathers. Because of their psychosocial problems, they tend to assault their children. There have been occasions sometimes the parents have been thrown child against the wall and sometimes step onto the chest of a child and then assaulting on the head and on to the eyes, causing a very, very serious injuries. At least I have seen number of occasions where a mother, you won't believe this, has thrown hot water, boiled hot water to the child. It looks very, very alarming, but then it's very, very important that you inquire about the history. I'm sure this mother definitely would have severe psychosocial problems. So you need to inquire about this and then try and prevent this kind of injuries. Kaushik, I have 10 more minutes.
You can carry on, sir. We actually, we can go more than 1 hour. It's all right. Because we'll have to, you can take your time. So it's all right.
Okay, right. Okay. Now, the mechanism is usually shaking. It's not just shaking like, rocking a child or something like that. It's like Nalavanuma or whatever, right? It's much more vigorous shaking and can cause serious injuries inside the eye. And you must remember to examine the children properly, because the hallmark of this kind of injury is that injury is in different stages of healing. Sometimes retinal hemorrhages, and sometimes they can have injuries all over the body, like previous scars on the body would give some kind of idea about previous assaults or injuries. This is actually called child battery syndrome. We don't use this word non-accidental injury very, very often, but I'm sure in forensic medicine, you have learned about this child battery syndrome. Remember that this is existing and we need to look for them because children are affected. They're precious to all of us. The consequence of this kind of injury would be 15% of them will have permanent physical problems. And virtually all abused children would have permanent emotional problems. And you need a lot of work, getting a good history and counseling them. Sometimes you have to refer them to a child probation department. You must have heard about this Lama probation and child health department. I don't know, I can't remember the Sinhalese version of this one. Parivasaha Lamarashka department. So I don't know, I'm sorry about the audience who speak in Tamil. I don't know the Tamil term for that. So we can refer to them actually. They have special programs to rehabilitate these children as well as they are advising their parents. Idea is to not to see any chance of recurrence of repeating this kind of injuries. Now, this is a severe kind of injuries that you see on the retina, massive retinal hemorrhages. Sometimes injuries in non-accidental situations, injury situations, or child battery syndrome, they can have violent shaking, and then stepping onto the child's chest can cause this kind of retinal hemorrhages. There can be sometimes permanent damage due to this. So this may be some important thing that you need to look for in your day-to-day work. I think that is it on traumatic ophthalmic emergencies. Perhaps you can see the slide on medical ophthalmic emergencies. I think I'll stop there. Hello?
Hello, yes.
Yeah, I just show this slide and start. Can I stop there, Kaushika?
We have some more time, sir.
How many minutes we have?
There are a few questions as well. So I think about half an
All right,
hour.
we'll answer questions. That's better. How many more minutes do I have?
We can go till 10 o'clock, sir. In fact, the link is active for about 2 hours. So
I don't know. Can we get any response from the audience? I don't know
yes,
the children.
we'll ask the students what they want to do.
Yeah. It may be boring, you know.
Do you want to continue with the medical emergencies or?
Yeah, I can. Of course, I can. Or else I can take questions also. I can do some other session if you like, whatever the way. Because since I don't have any interaction, children might be finding it very boring.
One student has they want to continue.
Okay.
They want to continue with it as well.
Right. Now, are they just Kaushika, just to make sure, are they final years? So
yes, most of them are final years and some fourth years also there.
So they have not had any of the final year lectures yet.
No, as far as I know, no, sir. No.
Right. Anyway, this will be repeated in the final year. I think probably I'm giving these lectures. Right. Doesn't matter. Right. It's quite useful. Knowing about medical emergencies as well. Right.
Right. Sir, we'll continue.
So we will continue. Or I can take questions, whatever.
I think the students want to continue, so they are typing in the chat box to continue.
Fine. Okay. Now, medical emergencies, if I were to list medical emergencies, there can be problems like orbital cellulitis, microbial keratitis, endophthalmitis, corneal melts, acute anterior uveitis, acute angle closure glaucoma, posterior detachment, retinal detachment, and then vascular insults like central retinal artery occlusion, anterior ischemic optic neuropathy, giant cell arteritis, papilledema, accelerated hypertension, and then eye movement problems like acute third nerve palsy and sixth nerve palsies. Now, can you see the full slide properly? Yes, you can see. Yeah.
Yes, I can be seen.
You can see. Starting from with orbital cellulitis, right? This is actually orbital cellulitis, or if I just tell you a little bit more about this entity of orbital cellulitis, actually what you see is periocular swelling. Now, periocular swelling or cellulitis in and around the orbit can be classified into two. One is, the first one is preceptor cellulitis. That is a situation where you have cellulitis in front of the orbital septum. So that's called superficial cellulitis. So the demarcation line is actually the orbital septum. As you know, orbital septum is the orbital periosteum, which covers the orbital cavity, which extends superiorly and inferiorly, and then attaches to the tarsal plate, upper tarsal plate as well as the lower tarsal plate. So behind the septum is deep cellulitis, orbital cellulitis. In front of the orbital septum is superficial cellulitis or preceptor cellulitis. Now, what we are dealing today is a more serious or dangerous situation called orbital cellulitis or deep cellulitis, which can cause a lot of problems. And causes would be usually secondary to infections around the eye. You know, the structures around the eye are basically air sinuses, like ethmoids and maxillary sinuses are usually the seat of the primary pathology. So infections can easily track from these sinuses to the orbital cavity. Now, symptoms would be frontal headache, fever with rigors. These patients are going to be really, really ill. They're not very well looking actually, and they can have double vision or diplopia and loss of sight. And signs would be fever, lid swelling, proptosis, chemosis or the conjunctival edema, and limitation of ocular movements. And then most important entity would be optic nerve compression. So that's going to be a really a devastating problem, because if you have optic neuropathy or optic nerve compression, patient is going to lose sight, lose vision. And complication, they can even have blindness, and then not even blindness, even death as a result of cavernous sinus thrombosis and intracanal abscess formation. Now, management, you must remember, this is potentially a life-threatening condition. Not only life-threatening, it's sight-threatening as well. So you need to admit this patient to eye department and need high doses of intravenous broad-spectrum antibiotics. We cover gram-positives, gram-negatives as well as anaerobes. And urgent CT scan and full blood count, blood cultures, and sometimes we seek the opinion of ENT colleagues to find the primary pathology. Now, this is a case of a severe orbital cellulitis. Now, again, you have on the picture on your left-hand side, the upper picture shows preceptor or superficial cellulitis. Now, if you want, you can force open the lid here, and if you carefully examine the eye movements, ocular movements won't be affected. There won't be that much of chemosis, and child is not looking that ill. If you look at this picture or the picture here, it's very difficult to force open the eye, and ocular movements would be severely limited. And child is, as you can see, child is looking very ill. Now, these two are cases of severe orbital cellulitis. Now, this CT scan, if you carefully see, here you see a large subperiosteal abscess, as well as you see a sinus opacity in the sinus, ethmoid sinus as well here. So, primary pathology would be in the ethmoid sinus. Now, you need to drain this kind of subperiosteal abscess. Otherwise, as you know, cavernous sinus is right there, and orbital apex and the cavernous sinus. This infection can spread to cavernous sinus, resulting cavernous sinus thrombosis and even intracanal abscess formation, which is life-threatening as well. So if you have any doubt about periocular swelling like this, do not take a chance. Please do refer them to the eye department. Even if it's superficial cellulitis, as you're pretty sure, try not to treat them. do refer them to the eye department. Now, causes of orbital cellulitis would be gram-positive and I told you about this one. And here is actually, I don't know whether you can you see the top of the slide? Kaushika, can you see the heading?
Yes, sir. I can see microbial keratitis.
Microbial keratitis. It's covered by a bar toolbar here, I think. I can't get rid of it. Doesn't matter, right? This microbial keratitis. Again, this can, the cause would be gram-positive and gram-negative organisms like Pseudomonas and pneumococci, Staph, E. coli, and Acanthamoeba. Remember, organisms like Pseudomonas and pneumococci can be really, really dangerous, and they can melt the whole cornea within 24 hours. This can be secondary to corneal injuries like corneal foreign bodies, contact lens wear, and loose stitches after surgery, and people with corneal anesthesia or exposure keratitis, especially patients in intensive care units with exposure and patients with facial palsies, etc. And symptoms would be pain, redness, discharge, foot phobia, and of course loss of sight. Signs would be corneal epithelial defects, localized white infiltrates in the stroma, and then hypopion. Hypopion is pus in the anterior chamber. And the management, again, this kind of case should not be managed elsewhere. It should be managed in the ophthalmic department. So refer to us as early as possible. Probably they need admission. And then we take a good history to find out the kind of mechanism of injury. Perhaps you can do that little bit, taking a very good history. Especially, many people with microbial keratitis are people who work outdoors, like farmers, fishermen, and people who really meddle around soil, and people who are involved with potential injuries to the eye and potential possible contamination with soil and organic material. So that history is very, very important for us to work out, because soil contains a lot of fungi. Sometimes these corneal ulcers or microbial keratitis can be secondary to fungi, which is very, very difficult to treat. And many of them go blind if you don't treat them on time. Sometimes we isolate them in isolation cubicle. As you know, we have 2 separate ulcer wards in the eye department to isolate them from post-op patients and other patients. Now these are pictures of microbial keratitis, and here you see a central ulcer there, and then you see hypopion or pus in the anterior chamber. And here the most important noticeable feature is actually circumcorneal injection. Now, if you see a sclera is injected, or these blood vessels are dilated and inflamed, heavily inflamed, do not think that this is just simply conjunctivitis or something mild. Always suspect something very, very serious, right? So circumcorneal injection would indicate that you are dealing with the sinister pathology. It's not simply conjunctivitis or mild thing. And then look at the cornea. Even with your torch, it's quite easy for you to diagnose. And corneal shiny appearance, so luster is lust. And then you have this white opacity. And you see this fluid level with white fluid. That is pus in the anterior chamber. If you see any of these signs, do not take a chance. Send them immediately to the eye department. Now here is actually a keratitis, microbial keratitis, corneal ulcer. Secondary to Pseudomonas. The whole cornea is melted, and there's no chance of survival of this eye. It's very likely. All we can do is do a corneal grafting. Actually, can do a limbus to limbus corneal graft. It's very unlikely that this patient can regain the sight. So we should not wait until this moment. Actually, if you are working in a periphery, or if you are posted to a peripheral hospital after your MBBS, far away or whatever, or wherever you work, please remember these signs and do not just putting steroids or antibiotics and keep quiet saying that patient is okay. Patient is not going to be okay. Patient is going to lose the eye if you just wait in situations like this. Right. And then endophthalmitis. Endophthalmitis is another devastating problem. Usually, this is secondary to surgery. Sorry. This is one of the most serious infections that we come across, and very disheartening problems that we see in eye surgeon's life, because you do a very good surgery and third or fifth day patient coming with severely infected eye, which we don't want to see. Most of the endophthalmitis, most of the occasions, endophthalmitis is secondary to surgery, usually cataract surgery. It can be due to cataract surgery, after cataract surgery, glaucoma surgery, even retinal detachment surgery can be the primary problem which can lead to endophthalmitis. Symptoms would be red eye, pain, reduced vision, and usually they present 3 to 5 days post-operatively. Signs would be conjunctival injection, anterior chamber reaction, severe inflammation of the anterior chamber. You may see a lot of flare or the proteins in the anterior chamber, as well as cells in the anterior chamber, so that anterior chamber details may not be very clear. And then hypopion is pus in the anterior chamber, and you may not be able to see the vitreous properly because of the anterior chamber reaction. And then hazy view of the fundus. Fundus may not be quite visible. And management, urgent referral is mandatory. It's very, very important that you refer as early as possible. And many of them need admission. We always admit these patients. And we take samples from the conjunctiva, aqueous, and the vitreous. And we inject antibiotics, usually cephalosporins and vancomycin intravitreally. Strong, very, very strong antibiotics to counteract the infection. Because if you can't arrest the progression, you will have devastating complications like loss of vision, total loss of vision. And then at the same time, we start them on intensive topical antibiotics almost hourly. The value of systemic antibiotics is highly debated. Now, acute angle Kosher glaucoma is another problem that we see in the ophthalmic department, and causes again, causes of the risk factors would be hypermetropia and hypermetropic cataract. Now, usually hypermetropes have smaller globe. Their eyes are very small. If you look at the axial length of the eye, in a normal person, it is about 23 millimeters. But in them, it may be 20 millimeters. So the eye is smaller. So that anterior chamber is relatively crowded or small. So their angle closure can happen very, very easily. Actually, the pathology is very, very complicated. Not only the anterior chamber anatomy or the hypermetropia, it is now known that lens is also play an important part in the pathology or pathogenesis of angle closure glaucoma. So that is the etiology of angle closure glaucoma. Now remember, this is again one of the very serious or significant ophthalmic emergencies, and symptoms would be severe pain, reduced vision, halos around light. Usually they see pain plus halos around lights. So they see this rainbow colors around lights. Actually filamentous light, not fluorescent lights. Nowadays you don't see that many bulbs with filaments. And now those days classically they describe this halos like, they say it's buduras like. They see buduras around lights classically. And then they can have severe nausea, vomiting, diarrhea sometimes, severe symptoms of visceral pain. So much so that there have been occasions where these patients have ended up in surgical casualty, suspecting acute abdomen. The surgeons were about to open up the abdomen, and then finally they find that there has been an eye problem, because the severe vomiting and diarrhea would end up with abdominal distension as a result of paralytic ileus. And so you have to be very, very careful. Sometimes this patient coming in pain and abdominal swelling, distension, may end up with surgical casualties, not thinking about the eye. So be careful. And signs would be reduced vision, red eye, corneal edema, mid-dilated pupil. Their pupil is mid-dilated, not constricted, not very much dilated. So remember that sign as well. And closed angle. We have a special technique of actually examining the angle with a special lens called gonio lens. So we just put some local anesthetic into the eye, and then we examine with this lens. We just insert this lens to the eye, and you can visualize the angle and then diagnose very, very positively the entity of angle closure glaucoma. And management, so if you have any suspicion, if they're coming with severe pain, loss of vision, halos around lights, and then they have red eye, especially circumcorneal injections, please do refer them to the eye department as early as possible. Okay. Now, the second thing that we do is lower the intraocular pressure. And medically with systemic acetazolamide and mannitol intravenous and topical drops like pilocarpine and beta blockers like timolol. So idea is to get the pressure down first, and then we use steroids to counteract the inflammation. The eye is heavily inflamed because of the raised intraocular pressure. Once the eye is quieter, we plan laser surgery. What we do is neodymium YAG iridotomy, that's called YAG iridotomy. Make a hole at the periphery of the iris, thereby short-circuiting the aqueous from anterior chamber to the posterior chamber, so that the passage through pupil is bypassed. and then that helps in opening up the angle once we make this tiny hole. And then if this also can be sometimes can fail, in that case we plan surgical iridotomy. When everything fails, sometimes we decide on lensectomy, do the cataract surgery, remove the lens. Thereby we remove the bulk of the anterior chamber, which actually it is now very well known that lens is also a major factor in etiology of angular Kosher glaucoma. So we remove the lens also when everything fails and put an intraocular lens inside. That also helps in management of resistant angular Kosher glaucoma. So important take-home message is that if you have any suspicion about angular Kosher, please do refer them to the eye department. If you carefully see this slide, you see the cornea is not nice and shiny. Your cornea is nice and shiny, it's transparent. You see this orange peel appearance, right? That is because of the corneal edema, right? Because the corneal dehydration mechanisms are not taking place because of very high pressure inside. So endothelium is not properly functioning. So thereby there's collection of water in the cornea. So the corneal shiny appearance is lost. You can even diagnose this with your torch. And again, look at the pupil, it's mid-dilated. And details are not very, very clear, right? And moving on to this slide, see again mid-dilated pupil, and you see this, there's a bulge of the peripheral iris. That's called iris bombae. Now aqueous is actually trapped in the posterior chamber, right? That is the chamber behind the iris. So what we do is we just make a tiny hole there, it's called peripheral iridotomy, and so that aqueous can release from the posterior chamber to the anterior chamber. That's what we do as a treatment in angular Kosher glaucoma. Now, retinal detachment. This happens usually as a result of retinal tear. Now, that is retinal detachment secondary to a tear. This is called regmatogenous retinal detachment. Now, there are some important predisposing factors like posterior iris detachment, myopia, like myself, people who are short-sighted, wearing minus glasses, and then sometimes trauma causing retinal tear, and then retinal detachment. Symptoms would be flashes, floaters, and sometimes shadow or curtain across vision. Usually this is painless. If somebody presenting to you with painless loss of vision without pain, you must always suspect something happening in the posterior segment, like retinal detachment. Now, signs, initially you may only have field defect, visual field defect, and then reduced central vision if the detachment has reached macula or macula is detached. Now, that's a very, very important sign. Because once the macula is detached, central vision is lost. You may be too late. If you can detect the detachment before the macula is off or macula is affected, the prognosis of surgery is very good, much better. So if they come to you with a field defect and with good vision, very likely that you are dealing with the peripheral retinal detachment with macula, intact macula. So if you do surgery in that situation, outcome is going to be very good. So they essentially need surgery Surgical management, there are two approaches: external buckling procedure and then internal approach, doing vitrectomy. Vitrectomy, that's removal of the vitreous, and then sealing of tears with laser or cryotherapy. All those are very technical details, but please do not miss retinal detachments. So what you need to remember here is that anybody coming with painless loss of vision, always suspect things like retinal pathologies like retinal detachment. And usually they have symptoms like flashes and floaters prior to the detachment, and then sometimes field defect. Remember these signs and act accordingly. Now here, the top picture shows a large retinal tear and with a retinal detachment. So the retina has just come off because there's fluid underneath. And this is a very diagrammatic representation of the same thing. You have a retinal tear here, the fluid goes through and lift off the retina, detaching the retina. So idea is, to what we do in surgery is that we just relieve the vitreous traction, or do an external buckle, and then we just drain this fluid out and then seal the tear. That is what we do surgically. It's quite rewarding if you do them very early, and then they can have their vision back. If not, if you are late, the process called proliferative vitreoretinopathy takes place. There's a certain amount of fibrosis happens in all detachments, and then ultimately the outcome is not going to be very good. Now this is central retinal artery occlusion. Now this happens usually secondary to atheroma. Embolus, like in the carotid artery, or cardiac embolization, or arteritis, especially inflamed arteries, like what you see in cancer arteritis, and raised intraocular pressure. And symptoms would be preceding amaurosis fugax, transient loss of vision, sudden painless loss of vision, and visual field defects. Signs would be marked reduced loss of vision, and usually they have relative afferent pupillary defect, whitening of the retina with cherry red spot, and segmentation of retinal vessels, and you may see an embolus. Now, central retinal artery occlusion is a devastating acute vascular pathology that we see in the eye department. Unfortunately, it's very unlikely that we can get their visions back. However, if they present within 12 hours, we can do things like ocular massage and anterior chamber paracentesis, that you remove a little bit of fluid from the anterior chamber, and rebreathing into a paper bag, increasing the carbon dioxide concentration, thinking that central retinal artery is going to be dilated and there can be any possible reperfusion. I haven't seen a single case of recovery in central retinal artery occlusion during last, say, 30 years in ophthalmic practice. And if more than 12 hours, there's no immediate treatment. But it's very important that you investigate thoroughly to find out the pathophysiology or basic pathology of the vascular occlusion, because you need to preserve the other eye, the only eye, and this patient can have any other thromboembolic complication like stroke. So be careful. You need to investigate them with at least basic investigations like ESR, C-reactive protein, and aspirin sometimes may be useful, but you need to refer them to the eye department for further investigation. We refer them to cardiologists and sometimes radiologists to investigate their carotids and then cardiac to exclude any cardiac pathology. Now this is what you see in central retinal artery occlusion. You see this area is very reddish and this area is very pale. This patient has a relative afferent pupil defect and possibly vision is almost like something like in the range of counting fingers or hand movements. Vision is going to be very, very poor. Now here the choroid spot is what you see there as a red spot is because, as you know, this area, the macular area or the foveal area, retina is very thin. So that choroidal sheen is easily seen in this area. When this, the macular area is edematous or whitish, with the contrast, this area is seen as a choroid spot with a much better contrast. So that is what is seen as choroid spot. Now here is branch retinal vein occlusion. Here you can actually, if you carefully see, the embolus is right there. This area is whitish. So this area is infarcted. So this patient may have certain amount of vision because inferior macula is preserved, but superior macula is edematous. Right? Now, this patient may not have total loss of sight. Now, since there's an obvious embolus, you need to find out the seat of embolus. Again, you need to investigate the carotids and the cardiac source. So it's very important that we get the opinion of the cardiologists and sometimes radiologists to find out the seat of the pathology or source of embolus. Now, the entity called anterior ischemic optic neuropathy. Kaushika, yeah. Kaushika, are you there?
Yes, I'm there.
Can I just take questions? I'm sure it's going to be boring for them.
Okay, sir. We'll take the questions then.
Yeah.
Right.
I think I'll stop there. Otherwise, it's going to be boring. 2 hours is too much for them anyway, right?
Okay. Yes.
Yeah.
So the questions, some of the questions are not related to emergency as well, sir, but
yeah,
I'll go ahead. Do hyperthyroidism and vitamin A deficiency predispose to premature cataracts?
Hypothyroidism?
Hyperthyroidism and vitamin A deficiency predisposed to premature cataracts.
I'm not sure about vitamin A deficiency causing cataracts. Not that something I know of. But of course, dysthyroidism can certainly be disposed to cataract.
Right.
Yeah.
Next question is, does corneal aberration need urgent eye referral?
Corneal aberration. Not really. If you can diagnose just an aberration, if you can examine this patient with a microscope or with a torch, if you're pretty sure about you're dealing with superficial aberration, you need not to refer. But nowadays, I think I advise them to advise anybody to refer this patient to the eye department because they are predisposed to secondary infections. So infection sets in, you're going to have a problem. So if you suspect something, any corneal injury, I think you better get the ophthalmic opinion.
Yes. Next question is, in what kind of injuries we see floaters and are floaters serious?
Sorry, what kind of?
In what kind of injuries we see floaters and are floaters serious?
As I told you now, in many of these blunt ocular trauma, if there's damage to Any blood vessels resulting vitreous hemorrhage, any retinal pathology like retinal tears or detachments, or sometimes inflammation. Second, inflammation can cause floaters. So that's related to trauma. Of course, trauma can certainly causes floaters. If you see floaters after traumatic injury, I think you need to do a very thorough fundus examination. So you need to refer them to the eye department, right? And then generally, floaters can be actually dangerous. Now, what the floaters do not really mean the floaters that you and me, all of us see floaters. If you carefully see, if you look at blue sky or a white wall, you may see tiny things like thread-like thing floating around, like tiny fleck-like thing. I mean, we all see that. Now, those are actually called physiological floaters. So, you see, you call them Masse volatilis. They are actually physiological floaters. Sometimes we can have tiny cells in the vitreous projecting into our visual field. Now, those are not really dangerous actually. But if you see sudden onset of floaters, especially after 40 years of age, or you see something like cobweb, or something like people describe like something like kondruyana or something, like a tiny thing floating around with flashes, some flashing light going towards the temporal side or nasal side or down or up, a kind of somebody flashing a torch or something, or they describe as kanamadiri or something, right? And that is very significant. So you need to do a thorough examination on them. They can have an entity called vitreous detachment, called posterior vitreous detachment. That need a detailed examination with dilatation and fundoscopy to find out and to exclude any potential tears. They can have retinal tears sometimes. So that is significant. Not that in this, many of us see this thing floating around. And of course, if you see more and more floaters, even physiological floaters, it's better to get your eyes checked. Any more questions? Yeah, Kaushika. I can't hear you.
A 55-year-old type 2 diabetic patient
Yeah.
presented with left eye pain and visual acuity for 3 days. Is it due to diabetic retinopathy or retinal hemorrhage or any other reason?
So the history is 55 years old patient.
Presenting with left eye pain.
Eye pain.
And maybe loss of visual acuity for 3 days. So they're asking whether it's diabetic retinopathy or retinal hemorrhage.
Yeah, I need to inquire about so many things anyway from this particular patient. You need to go into real history because eye pain can be anything.
Yes.
It may not be related to diabetes at all. But then, you know, as this patient has been a diabetic for a long time, a painful red eye, if the eye is injected and the red eye may be due to secondary glaucoma like neovascular glaucoma. And you need to inquire about the other IOs. This anyway, any diabetic, we are extra careful, especially diabetics, long-term diabetics, like, you know, diabetics going on for many years, like duration more than 10 years or so. We need to do a thorough examination. And the important thing is if the patient is a diabetic, the message is that they need to get their eyes checked at least once a year. So I need to get more details about this patient actually.
Yes.
You know, otherwise this can be anything. It may be totally unrelated or related.
Then they have asked, can viral conjunctivitis cause halos around light and small irregular pupils?
Not really. The conjunctival, yes, I'll answer that. That's an important question. Conjunctivitis itself would not cause any visual problems, but then there's an entity called keratitis. Because after about 7 days, they can develop inflammation in the cornea called keratitis. It's actually an antigen-antibody reaction, immunological reaction, where there are tiny patches on the cornea. Now, these things can scatter light and causing halos around lights, right? And secondly, sometimes some people tend to describe, of course, we do not use steroids unless there's keratitis. With steroids also, their eye pressure can go up. Then again, if the pressure goes up, they can have halos around light. So there's another possibility. But usually conjunctivitis, viral conjunctivitis per se would not cause any of those problems. But then if they have keratitis, yes, they can have halos around lights and blurring of sight. Yeah. I can't hear you again.
Yes, sorry, sir. Can hypoparathyroidism, neonatal oxygen therapy, conjunctivitis cause premature cataracts? Hypoparathyroidism, neonatal oxygen therapy, conjunctivitis cause premature cataracts.
Yes. Then?
Neonatal oxygen therapy.
Neonatal oxygen therapy per se would not cause cataract, and then the question is, this patient is very prone to develop the entity called retinopathy of prematurity, right? That's a big entity, right? So we actually now we have very good service in Cinema Bandaranaike. They do everything for all these susceptible babies, right? So once if they get advanced retinopathy of prematurity, they can end up with cataracts, but that's very, very late stage.
They have asked, can acromegaly cause proptosis?
Acromegaly cause proptosis? Not really, unless they have a massive tumor.
Yes.
Of course, if they have, occupying whole of pituitary, and I have seen missed pituitary tumors causing proptosis, that's very late stage. Of course, before that, we should be able to diagnose them anyway. Theoretically, yes. If you really miss it.
They have what are the indications for interference in what are the indications for interference in squints and what are the management options? I think what they want is what are the indications that we should actively
indications for interference, is it?
Yes, in squints, and what are the management options?
Management option. Now that's a huge topic, I need 2 hours to discuss that question anyway. Depending, there are squints which can be, sometimes there are squints, especially isodeviations called accommodative isodeviations, can be treated with spectacles sometimes. Sometimes with special exercises, orthoptic exercises to strengthen eye muscles. And sometimes we have to think about surgical options when everything fails. We don't jump into surgery in almost every case, but there are other ways of managing conceptually, depending on the entity, the diagnosis we're dealing with. And many of the squints need not to do surgery. We can observe sometimes squints can even disappear, especially exodeviations like hidden squints, like latent squints can disappear. So we need them, we need proper follow-up, of course, to prevent blunting of vision in one eye, like you call it amblyopia. And so that vision can go down in the squinting eye. So anyway, children they need follow-up.
Question is, do the tetanus prophylaxis dose we give differ in each traumatic injury, or is it independent on the type and degree of injury? Maybe they want to know whether we have to repeat the tetanus dose.
Not really, no. It's the standard way of giving it. If you have, yes. have in 5 years or 10 years cover something when you give 3
Yes.
injections, 3 consecutive
Yes.
injections. Yeah.
So,
So that's it. You don't need not to.
do we always have to do a urgent eye referral in subconjunctival hemorrhage?
Not at all.
Yes.
You're pretty sure you are dealing with. I said that, it's something you can manage. That is the idea of doing these lectures. I said common ophthalmic problems, that's a separate entity. That's something significant that you need to know. So you can just prevent unnecessary referrals. The patient is fine, the vision is fine, no other injuries, right? And just subconjunctival hemorrhage, do nothing. Just you can safely send the patient away.
Can a cataract in one eye produce an afferent pupillary defect in that eye?
No, cataract has nothing to do with afferent pupil defect. Actually, afferent pupil defect happens because of the problem with the optic nerve pathway, the retina and the optic nerve and optic nerve pathway. With the cataract, of course, you can have afferent pupil defect. That kind of cataract, there's no point in doing because patient won't get any vision. Cataract won't cause afferent pupil defect, but then there can be cataracts associated with afferent pupil defect because we always check the pupil to assess actual prognosis. If there's a cataract with APD or afferent pupil defect, you can tell the patient, you're pretty sure that patient is not going to gain vision.
It's a question about foreign bodies. If we get a foreign body in the eye and if you are working in a rural hospital, with a patient who has an intraocular foreign body, how are we going to manage? I think you answered that question in the foreign body part as well. So
intraocular foreign body, if you have any suspicion, please do transfer to the eye department as early as possible, especially if you suspect any metallic. Any penetrating ocular trauma, any suspicion about ruptured globe, please do not try to meddle around them. Send them as early as possible.
There was how vitamin C aid in chemical eye damage.
Vitamin C is anyway, it helps in healing, isn't it? I can't remember the exact, the way it really helps in the molecular level. I can't remember now. But then, as you know, it enhances collagen synthesis, isn't it? So that's how it helps in
wound healing. Yes.
Yeah, wound healing.
In ruptured globe, do we need to give analgesics, steroids, and antibiotics before the referral?
No, not at all. Not especially, you can give some analgesics orally, right? But do not put any drop, any kind of eye drop, steroids or anything, because your ocular contents are out and they are very delicate structures and we don't know how toxic all these antibiotics are or eye drops are. So do nothing. Just put a plastic shield on top of the eye and send them.
Next question is, what are the common causes of blindness in Sri Lanka?
Interesting question. I can go on, keep on. This is my pet subject, talking for hours and hours. The commonest cause of blindness in Sri Lanka or elsewhere is cataract, number one. Number two would be globally glaucoma, but in this country, in our study we did in 2008, we found that macular degeneration, this is above 40 years of age, right? The macular degeneration is the second commonest cause. And third comes glaucoma. And I think before that, before glaucoma, after macular degeneration, you have uncorrected refractive errors. And then glaucoma. And then, then you have the whole big list. So number one is cataract, macular degeneration, uncorrected refractive errors, glaucoma. Then of course, then I'm sure the diabetes is coming up very fast. Diabetic endopathy as a major cause of blindness in this country. Because 1 in 3 or 1 in 4 is a potential diabetic in this country, isn't it?
Yes.
So that's going to be a huge problem in time to come. Especially when you are going to be consultants and manage the medicine in this country, you're going to be having real challenge in managing diabetics. But we have to be very, very, unfortunately, we don't have proper diabetic screening program in place yet. So we had to strongly think about it. I think the final year medical students need to be thinking very hard about this, especially sending them early without any delay. We still see many patients, diabetes for 15, 20 years, not referred, coming blind. It's too late. There's nothing much we can do about them.
Yeah. Out of next question is they must say is black fungus. I think they must have with this black fungus that is going on with COVID infection. They have with the black fungus associated with COVID is also a type of microbial keratitis. The question is, black fungus COVID also a type of microbial keratitis?
It is microbial keratitis. 30% of them, what we see is actually the fungal infection. But I'm not sure it's this particular fungus, black fungus, can be associated with this. Sometimes we call it a species called nigra. Nigra is black, I think. I have seen even the orbital. Is it? I can remember. We have presented this case of things like mucormycosis, and I can't remember now actually. These things are existing in this country as well because these fungi, they live in soil. So there's nothing new about this one. I'm sure even enough cases have been reported in this country. The association with COVID and how it comes, I don't know.
Yes. Next question is, what is the antibiotic used in endophthalmitis?
Endothermitis, actually, we are not sure about the origin we are dealing with. Well, we use vancomycin and third generation cephalosporins intravitreal initially. Intravitreal injections, we use 3 consecutive injections in 3 days. And of course, topical antibiotics like moxifloxacin, gatifloxacin and things.
Next question is, can partial retinal detachment be treated with medications only?
No. No medication for detachments. If it is rheumatogenic retinal detachment, right, there are simpler techniques where you sometimes inject gas inside the vitreous cavity called pneumoretinopexy. There are special, selection criteria for that. You need special candidates. But the treatment is always surgical. No medical management.
Next question is, if a patient presents with painful red eye, plus loss of vision, dilated oval pupil, plus photophobia and vomiting, is it angle closed glaucoma or anterior uveitis?
Very likely it could be both entities, but then very likely that it's better for you to think about angle closure and send the patient as early as possible. It could be uveitis. Uveitis also mimics angle closure sometimes. You can have secondary angle closure in uveitis. Depending on the history again, the careful history taking is very, very important. Angle closure is usually an acute event. They can have acute and chronic angle closure also. But then usually angle closure, acute events, sometimes they may see halos around light, as I mentioned earlier. And especially the classical candidate is a lady about 6 years of age. They used to get this.
Can diabetes be a risk factor for retinal detachment?
Diabetes is what happens there is diabetes. The retinal detachment happening in diabetes is the pathology is different. There you get a tractional retinal detachment because of proliferative diabetic retinopathy. There is actually a fibrovascular element dragging the retina and causing retinal detachment. So it is a risk factor of retinal detachment, but then diabetes per se won't cause rheumatogenic or detachment secondary retinal tear. But then say, yes, certainly diabetes have detachment. They develop detachments in late retinopathy if you don't manage well.
Then they have asked, what is arc eye? What is arc eye?
They must be thinking of this, the arc burns. These welders, sometimes they don't use the cover, the guard,
Right.
and then they can have epithelial burns. Usually they recover, when you can just give some artificial teardrops or ointments, something, they usually recover. They can have tiny burns on this, the epithelium.
Then they have asked how to check the RAPD.
RAPD, yes. I need to have a patient and tell you exactly. RAPD is actually, you just check three things. First thing is to flash the torch to, you just imagine my right eye has RAPD, flash the torch in the right eye, then pupil won't constrict. And then you check the consensual reflex as well. And then if the consensual is not working properly, you know that I might have problem in my right eye. And then there's a thing called swinging flashlight reflex. It takes half an hour for me to explain. That even average postgraduate takes 6 months to master pupil examination. So that's a good question anyway. So just check the direct light reflection consensual at your level, I think. Then if you have any suspicion, ask somebody who knows better.
Basically, that's it. So that's the end of the questions.
Yeah, nearly 10 o'clock now anyway.
Yes. So in that case, we'll wind up.
Yeah.
So on behalf of PeMSAA, I would like to thank you, sir, for giving this very informative lecture on ophthalmic emergencies. In fact, I'm very grateful to you. About 3 weeks back, when I contacted you to conduct this, to organize this lecture, without any hesitation, you agreed to do it. So once again, thank you very much, sir. And I would also like to thank the PeMSAA Council for organizing this series of lectures. Thank you.
Thank you, Kaushika. Thank you, actually. I'm very happy to do, I really enjoy teaching. Unfortunately, we are having a very dark patch these days.
Yes.
So if you give me some more opportunities, I certainly would take part, right?
Definitely, sir.
Okay, thank you so much.
Thank you very much. Thank you.